Hello and welcome to week 2 of HCA 528 Health Policy. So our agenda for today's discussion will be, I'm going to go through an overview of the various health systems that have come up over time. The idea is to give you an idea as to why our system is set up the way that it is and what its origins may be in terms of other systems or approaches that we have seen throughout history. I'm going to talk about some basics of health insurance, as that is a primary driver for how our system operates in terms of delivery of care. We'll have a link to a YouTube video, which is a healthcare TED Talk on where healthcare has perhaps fallen short in terms of our own expectations, and then we'll talk about this week's discussion. So first of all, before I get started on that, a couple of housekeeping items. The individual research paper topic is that is due at the end of this week. So please get that into me. Also, the subject for your group project work is also due this week. I'm expecting that your groups will have communicated, will have met virtually or in person or however, and started to organize yourselves. And I would like to see the subject you have chosen by the end of this week. That subject being either the research project on healthcare costs or the research project on hospital readmissions. So with that out of the way, let's get into an overview of healthcare systems and how those are put together. So there are a number. First of all, when it comes to healthcare systems, there are 5 pillars that are applied to all healthcare systems. Number 1 is access, the ability to obtain services. Number 2 is quality. Are services provided based upon the best evidence of positive outcomes? Are patients getting the kind of care for any condition that they may be presented with? Are they getting the kind of care that they would expect? Cost, are the services being provided at a cost that would be reasonable for all parties concerned? Equity, do all persons receive care equitably? Are you receiving care based irregardless of where you may be in terms of any kind of socioeconomic standing or position? And then population health, is our population as a whole being well served? Are we providing for a population which is healthy, has a high quality of life, and has a productive quality of life? So let's talk a little bit about national models of healthcare. We have a few out there. We have what's called the Beveridge model, the Bismarck model, the national health insurance model, and the out-of-pocket model. So let's talk about each one of those and how they may be related to where we are today. The first I want to talk about is the out-of-pocket model. So this is essentially market-driven healthcare, and this is something you'll find in less developed areas that don't have resources for mass medical care, such as rural areas of India, China, Africa, South America. You'll often find this. This was common in the United States prior to health insurance coming on the scene, and essentially is you have healthcare services that are available. If you can pay for them, you can get them. If you can't pay for them, you don't get them. So the market, this is very classic market-driven. You are providing services at a cost, and if those services are something you could pay for, you do it. Otherwise, you go without. There is a theory among at least some areas that health insurance, the means of having insurance cover different sources of care, actually serves to increase costs because the cost is insulated from people and their choices in terms of making healthcare decisions. But there are other voices who advocate equally strongly that if we were to simply go to that kind of a model, you would have a huge percentage of the population simply not be able to have access to healthcare at all, and that would be a very inhumane way of approaching healthcare. But that is a system that is out there and has been used, and even in today's market, you see some signs of that, and we'll talk about where that comes in as we go in later on in this discussion. The second model is what's called the Bismarck model. Now, the Bismarck model actually comes out of the late 19th century. It was created by the then Chancellor of Prussia, which ultimately became part of Germany. His name was Otto von Bismarck. And the idea was that you had health insurance, which was jointly financed by employers and employees, and the services were offered by private physicians and institutions and paid for by that insurance. This is probably the closest representation to the classic American healthcare system that we have. We have private health providers for the most part, and we have private health insurance, whether it be a Blue Cross plan or a United Healthcare or a Cigna or an Aetna or any of those systems that are out there. So the Bismarck model, I would say, represents the bulk of the way healthcare is provided in the United States, or certainly a large portion of it for the working age population in the United States. The next piece I want to talk about is called the Beveridge model. Now, this was created by a person named William Beveridge, and that is the opposite of the out-of-pocket model. So you have healthcare is managed and provided entirely by the government. So in that situation, every physician, every nurse, every practitioner, every radiologist, everybody who deals with healthcare from top to bottom works for the government. So and it is all paid for by tax revenue, which flows into the system. So it's also known as socialized medicine, or it's often been called that. One example of a system like this would be the UK Health Service, where everybody who provides any kind of service for healthcare at all works for the government, and that it is seen to be a core government function. So, and there are many systems operating under that model today. The next model I want to discuss is called the National Health Insurance Model, and this is a combination of the Beveridge and the Bismarck models. So in this situation, you have a government-run health insurance component. So the payer, the health insurer, is actually the government, and the providers deal with that single payer, which theoretically holds down costs. But the health providers themselves are still largely private sector. So this, in terms of a country that runs this, the most close comparison would be the Canadian model. So you have a national health insurance provider dealing with a network of private health insurers. Another system that would be very closely representative of this in the United States is Medicare and Medicaid, because in that situation you have either the state in the case of Medicaid, or the federal government in the case of the Center for Medicare and Medicaid Services, or CMS, is the payer for all services under those programs, and the health providers are largely private sector. So that is a very that forms the bulk of the private sector and public sector partnership that you see within the United States. So, given that a lot of care that is provided in the United States is provided via private health insurance, I thought it was important to discuss some basics of how health insurance runs and operates here. So the principles of health insurance is that the people who have health insurance coverage are typically called members by private health insurance plans, and they're called beneficiaries by government plans. So if you see those different terms, it's a question of who's doing the counting in that perspective. Insurers charge a premium for their health coverage, and that is based upon the relative risk of the insured population that they are covering, and so that relative risk is an important component. So groups that are typically younger and healthier cost less than those who are older and sicker, because the younger and healthier groups aren't in need of as much ongoing health care as a population, as opposed to the groups of people who are typically older and sicker. Now, it is, because healthcare is so unpredictable for the health consumer, insurance premiums level cost is associated with that consumer. So you may be in a health insurance plan, and you may go years without doing anything more than seeing your primary care physician for the occasional checkup, and you may feel that you're paying more in premiums than you're getting in services. But then you may come up with an event that all of a sudden you generate tens of thousands, even hundreds of thousands of dollars in payments in a relatively short period of time. I had a very close friend of mine who would fall into that category. She was very, very healthy, very athletic. Really was one of those people who never really had to deal with much of anything from a healthcare perspective. And then out of the blue, she was diagnosed with a brain tumor. And so she goes from having virtually no healthcare expenditures at all to expenditures that literally ran into the millions of dollars as she was dealing with that. So that's where health insurance premiums level out those highs and lows in terms of what you may be coming into. Without health insurance, we're all one health incident away from an event which could be not only catastrophic physically, but catastrophic financially, which is why health insurance in this country is so important. So there are several key insurance terms that you will probably hear if you have not heard already, that I do want to discuss and make sure that you understand. The first is premium, the amount each person pays for insurance. And as I mentioned, that can vary based upon the group of people that you're being insured with. So if you are working for a small employer, and the employees in that small employer are relatively young and relatively fit, you may have a lower insurance premium than people who may work for an employer where you typically have older employees. And so then the risk profile of those will have an impact on that premium. Then there is the payment, how much an insurance company will pay for a covered service. And in some cases, those payments are they're negotiated in advance for a certain service at a certain code will receive a certain payment. You have a deductible, which is there's in most health plans a person who is covered by insurance has a certain minimum cost that they have to incur before the insurance kicks in, and that percentage of cost or that amount of cost can vary with the type of plan that you have. And there was one of the items that we talked about last week was the issue of the health savings accounts dealing with what are called high deductible plans. What was happening over the last number of years was as costs were increasing, health insurance companies did not want to have premiums with that totally reflected those costs at the current deductible rate. So what they did was they raised the deductible significantly, to the idea being to give consumers more of a choice for what services they were going to seek out or not seek out. This has had a variety of consequences in our systems, both foreseen and unforeseen, as we have been going forward. And this is essentially a way to reintroduce the out-of-pocket cost model back into our healthcare system by imposing these higher deductibles. Then the next item you have is co-payment. This is a fixed amount paid by a member for a service. These are becoming less and less common as different in terms of different care plans, but they are still out there. So that is essentially, you go to get a piece of medication is $10, or it's $5, or it's $50, or you go to some plans, if you go to an emergency room, it's $200. So these are this is a set amount that you pay for a service. The other item is a co-insurance, and this is becoming more and more common. You'll have a percentage amount paid for a member by a service. So this is designed essentially to drive members to obtain coverage at providers that an insurance company calls preferred providers, usually because they have negotiated some type of preferred costing arrangement with that particular provider, or that provider sends a lot of patients to them, so they understand what that provider's track record is. So insurance companies create what are called tiers within their coverage. They'll typically have in-network or affiliated network or out of network, and those will create different levels of co-insurance requirements at each of those points. A few other health insurance terms I do want to talk about is out-of-pocket maximum. This is the total amount. Remember, this is a total amount the member is responsible for insurance covers all expenses. And so you may have a situation where you're very, very severely ill, and you have paid out a certain amount for deductibles over a period of time. You hit a certain ceiling, and then they say you're done. You don't have to pay any more for that. So that's for people who are typically very, very sick. You have a lifetime limit. This is currently not something permitted under the Affordable Care Act, but we've seen it in the past. And this is kind of the opposite of the out-of-pocket maximum. This is the out-of-pocket maximum for the insurance company. So it's a maximum amount an insurance would pay for any given member. That's currently not permitted within the Affordable Care Act as it is constituted at the moment. Stop loss. You have basically, this is essentially insurance on insurance. So, and think of a lifetime limit is not allowed for a member, it is allowed for an employer. So there is no cap on what an employer may theoretically be responsible for. So a stop loss would be a coverage whereby an employer would be able to essentially get insurance on their insurance. And so if you had a very, very large claim come through, that insurance would cover that very, very large claim. So going back to my example of my friend who had the brain tumor, her claims would have most certainly been covered by a stop loss through her employer, because of the level of expense that those were bringing up for her particular employer. Then you have what's called subrogation. This is essentially when one insurance company bills another. And an example of this would be you're in a car accident and you were hit by somebody else, and your medical claims for your car accident were created by the actions of the person in the other car that hit you. So in that situation, if that were the case, the person who hit you, your insurance company would bill their insurance company for the claims on that. And those of you who have ever been in any kind of a car accident, you will have probably received a letter from your insurance company asking, is this an at-fault situation? Did something else cause this? Is there some way we can essentially bill somebody else for the claims on this? Because you would not have, and legitimately, you would not have been seeking medical care if that person had not hit you in that situation, which is why you have subrogation for. So there are two major ways that are out there to purchase plans. First of all, we have group plans. This is still the most common way people obtain insurance. And so you work for an employer, your employer provides health insurance, and you have a shared benefit between the employer and the employee. In some percentage. There are a number of percentages out there. A common one is 80%, 20%. I've seen other splits on that, but that is still the most common way people obtain coverage. The other way people can obtain coverage is you can buy a plan individually, and one of the things that's come out there as a result, in a large measure, of the Affordable Care Act, but it was coming up before that anyway, are the health exchanges, where people can buy insurance on the individual market by participating in exchanges where you are essentially joining a risk pool, and so you can obtain health insurance coverage that way. And also, in many cases, those exchanges will provide some degree of subsidy for people who are at low income rates and who need to get care on a less expensive basis based upon your income profile. In terms of how premiums are priced, a health plan can only use five factors. First of all, is age. Premiums can be up to 3 times higher for older people than for younger people. Age is still one of the primary predictors in terms of a person's level of risk within health plans. This is why when President Obama pushed through the Affordable Care Act, one of the things that they did was to provide the ability for parents to retain their working age children on their health plans until the age of 26. The idea was that these people were just sliding through, not getting health insurance coverage at all. But this is a group of people that we want in the health pools because they are typically younger and healthier and will cost less money. Because if they're going to be bringing in a lot of other people who were uninsured into the plan, if those people were all older and high risk, it would have driven up premiums to the point that it would have been unpalatable for people who are currently having healthcare coverage. So age is still a big issue. Location, where you live, has a big effect on premiums in terms of different areas, different kinds of health risks. We'll talk about this a bit more when we get into the section on social determinants of health and how that can have an impact. Tobacco use, certainly, if you are a tobacco user, you're going to be paying higher premiums. Whether you have an individual or family plan in terms of enrollment, if your insurance coverage is only covering you, then you'll be paying a smaller amount, obviously, than if you're covering either your spouse or if you're covering a family on it. And then there are categories of different plans. They have different cost-sharing arrangements which are typically bronze, silver, gold, platinum, and catastrophic. So platinum plans, so bronze plans usually have lower premiums and higher out-of-pocket costs. So those are your high deductible plans. And platinum plans are the opposite. They have the highest premiums but the lowest out-of-pocket costs. And the kind of plan that you may want to choose will really depend on your own profile. If you feel that you are in a situation where you're not likely to need more than the occasional doctor's visit and maybe issues once in a while, a bronze plan may be fine for you for what you're trying to do. If you have significant pre-existing conditions that require lots of medical intervention, lots of potentially some medications or physician visits, then a platinum plan may be a better choice in that situation because you'll be otherwise, so that you can avoid deductibles. Now, another component that I want to mention briefly, and we'll talk about this in greater detail later on in the course, is managed care. So this is a payment mechanism where it can either be health maintenance organizations, preferred provider organizations, point of service organizations, exclusive provider organizations, physician hospital organizations, patient-centered medical homes, integrated delivery facilities. This is a way to unify delivery of services across the spectrum within healthcare. It is often used as a way to both improve the quality of care and also manage cost of care. So the piece that I do want you to check out, you can get the link to this on Canvas, is a TED Talk from Dave Chase talking about how healthcare stole the American dream. He talks a lot about the system and its shortcomings, and I encourage you to watch that. And finally, as far as our discussion topic for the week is concerned, I want you to give me your thoughts on what was the one thing you would change in our healthcare system and why. This is a standard discussion. We'll be using our standard grading rubric for, and I'd be interested in your thoughts on that. One of the things that's very interesting about our healthcare system and how we go about making changes to it is that because it is a large and complex and intricate system, there is more than one way to solve this problem. And this is a time where we need everybody's ideas and opinions to help us be able to do that. So please, I'd be very interested in reading your thoughts on that, your discussion items, as well as your responses to other people's thoughts and opinions. So on that note, I wanted to thank you for watching, and I will look forward to your I'll look forward to your comments. Thank you.